By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another episode of Nets Get Real with NK, and I'm your host, Mike Wayman. Again, here this month, we were a little bit delayed in the recording of this episode, but we wanted to make sure that we got this episode in since when we were at New Orleans this past month, or in May. It was the most voted on topic that everybody wanted to hear, and I wanted to make sure that I got this specialist here to present this particular topic. But before we get into everything, I do want to say thank you for joining us. This presentation is brought to you by TerSera Therapeutics and ITM Radio Pharma. Thank you. They're amazing sponsors. So go check them out. Also, our next conference is going to be September 28th in Nashville, Tennessee, Cambria, Nashville Airport. It is going to be an awesome, long day full of plenty of awesome speakers, headlined by Dr. Robert Ramirez from Vanderbilt. That's going to be a great program. For those of you who are looking for other content, extra content from NCAN, we do have, if you're listening to this the day that this drops, this evening, July 3rd, at 7 p.m. Eastern, we will be doing a Spanish-speaking live stream. It's a presentation with Dr. Heidi Del Rivero, as well as Michelle from Nets Mexico. They will be talking about new therapies for NET treatment, and that's going to be in Spanish. So, without further ado, I'd like to welcome our prestigious guest today from the University of Miami, Dr. Aman Chauhan. How are you, sir?
Thank you so much, Mike. It's always a pleasure and an honor to talk to the NCAN family. And congratulations again on recent wonderful conferences at various venues. And good luck with the national ones. I will surely sad to miss it. But viewers, do check it out. They always pull up a great show with some of the best speakers and a very nicely condensed summary of what's happening in the neuroendocrine cancer world. But great to be here, and thank you for giving me an opportunity to talk about this such an important topic, the PRRT. And
so we actually did a poll. We did a poll with our attendees at our last conference, and we're going to be doing that more on social media. On our social medias at Net Cancer Aware. Where we want to know what you want us to talk about. We want to know what topics you're looking to get covered. And the first most requested topic was the truth about PRRT. And I couldn't think of a better person to do this presentation than Dr. Aman Chauhan, because he is like the guy. He has done this. If you go on our YouTube, you will actually see other presentations where he talks all about this. But we wanted to give a little bit more of a quick, broader overview, and he's going to talk to us a little bit about that right now.
Absolutely. Thank you so much, Mike. Appreciate it. I think it's a very important topic. So for the unversed, greetings from Miami. My name is Aman Chauhan. I'm a medical oncologist. I lead our neuroendocrine cancer program. And I also co-direct our Theranostics program at Sylvester Comprehensive Cancer Center at University of Miami. Today, we will talk about PRRT. You've heard a lot of buzz about PRRT. Actually, it's been now available to our patients for a few years. And today we will basically talk a very high level overview about what PRT is, when do you need to do it, and when you maybe don't want to do it. So you're aware of neuroendocrine cancers. It's a rare disease, but it's highly prevalent because our patients live longer. So the cumulative prevalence of disease puts neuroendocrine cancer among some of the top cancers. The burden of disease is quite high. There are over 170,000 patients with the diagnosis of in the neuroendocrine cancer in the US alone. And because of such a uh, high burden of this cancer, we had to develop new treatments, and we have made a lot of progress in last decade with several effective treatments that we can use for our neuroendocrine cancer patients. And arguably one of the best treatments, or most effective treatments, I won't say the best, but the best treatment is very individual for individual patient, but arguably one of the most effective treatment is PRRT. And currently we have lutetium 177 dotatate, the only FDA approved PRT agent called Lutathera, the brand name in the US. But a lot of really exciting drug development happening in this space. So watch out, there might be newer players, newer drugs, and it's great for providers as well as patients. This whole field is getting better and better. So today we will talk about PRRT. What is it, and when do we recommend this treatment to our patient, and when not? Before we get into the PRRT, let's kind of understand the concept of PRRT. This is a type of drug which is classified under the theranostics drugs. In cancer treatment, we have different type of treatment: chemotherapies, hormone-based treatments, targeted therapies, radiation therapies, surgeries. So this is a novel form of treatment, or it is a radioactive treatment, but in the form of medicine. PRRT stands for peptide receptor radionuclide therapy. Let me kind of explain it with an illustration. Now, neuroendocrine tumors are unique because they express somatostatin receptors on its surface. So think of somatostatin receptor like a lock. These locks are present on the surface of the tumor cells. Okay. So these locks, the somatostatin receptors, the key for them, the somatostatin analog, only goes and joins to the lock, right? So if you have a drug like sandostatin or lanreotide, when you inject these drugs, it circulates in your blood, goes into the tumor tissue, and eventually binds to the tumor, because the key, the somatostatin analog, binds to the lock. It doesn't go and join some other normal or abnormal cell in your body. Now, what if you make this key radioactive, right, and then inject this drug? Then basically you will be able to take this radioactive key and just latch it to the lock in the tumor cells only, bypassing normal cell getting exposure to radiation. So there, initially, what we do in this concept is we tag it to a low, radioactive moiety like gallium 68 or copper 64. But the idea is to detect these tumor on a scan. And if we are able to detect these tumor on the scan, then we flip this into a more heavy duty, more heavy hitting, higher dose of radiation like lutetium 177. So if you have these keys tagged on with lutetium 177 and you inject this, it'll circulate in your blood, go find the tumor, lock to the tumor, and then take that radiation to the tumor directly. This is the precision way of radiating the tumor and bypassing radiation exposure to normal tissue like bone marrow, kidneys, and normal organ where we don't want radiation. And that's the key advantage of this concept of theranostics. One, you're able to first detect the target on a PET scan, screen the patient if they are appropriate candidate for the treatment, and later give the treatment which safely radiates only the tumor and bypasses normal organ. And that's the beauty of theranostics. So Lutathera is one of the theranostics drugs. There are other in the market for other cancers and several more coming down the pipeline for various tumors. But Lutathera by far is a very important drug and is the flag bearer for theranostic drugs, at least in the neuroendocrine tumor space. So you see the drug is a lutetium-177, which is bound to the dotatate, which is the somatostatin analog, which then binds to the somatostatin receptors on the tumor cells. All right, so this sounds cool, but does it work? Well, the best way to know whether any drug works is through scientific study via a randomized control trial. Okay. So this particular drug was tested in this large international randomized control phase 3 study called NETTER-1. The the publication is available publicly free of cost. So if you just Google NETTER-1, you should be able to find the full paper, all the details, supplemental data for yourself. So the study had two arms. Half of the patient got Lutathera or lutetium-177 dotatate. Another half got higher dose of somatostatin analog, the sandostatin drug. At that time, we did not have a lot of really good treatment options. So the comparison was to, at that time, the best established control. What we noticed was the patient who got the somatostatin analog, the higher dose of sandostatin, their tumor was controlled only for around 8-9 months. That's it. And this gray line depicts the median progression-free survival of those patients. On comparison, the line on the top of the graph, the green line, these are the patients who received Lutathera, had a tremendous benefit. Their cancer was stable for almost 28 to 30 months. So this is a significant improvement in disease stabilization with the help of this radiopharmaceutical drug. And this is the reason why we are currently using Lutathera to treat our neuroendocrine tumor patient. Now, a lot of our cancer drugs, they're effective and they are able to slow the cancer down, but comes with a lot of side effects and makes patient feel sicker. And that's one of the common concerns and reports from the patient with the chemotherapy and other treatments. Now, theranostic drugs or PRRT drugs are unique in the sense that, at least in the studies, what we found, the patient who got Lutathera actually reported improvement in quality of life. They felt better with the drug, which is great. This is a win-win for us because not only are patients, the disease was stable for longer, but they actually also felt better, not worse on the treatment. So based on these findings, FDA approved Lutathera in the US. And finally, we had access to this really important drug. And we no longer had to send patients out to Europe or Asia or some other country where this treatment was accessible for several years prior to that. It's also very convenient for our patient. This is limited dose treatment, only 4 infusions, as you can see the 4 IV bags here. So each treatment of Lutathera is spaced every 2 months. And every time you get Lutathera, you also receive amino acid solution to protect your kidneys. We don't want this drug around your kidneys and radiating your kidneys. So this amino acid solutions prevents the exposure of this drug in the kidney tubules and the radiation damage there. So pretty straightforward, 4 doses. Each dose is just every 2 months. So patients like it because it's not something that they have to come every week or every 2 weeks for infusions, and it's limited time dose. And it is effective, as we've seen. It is able to control disease in majority of patients for a significant amount of time. So that's the basics of what Lutathera is, what is in general theranostics drugs and PRRT. Now let's talk more higher, broader picture items or clinical pearls when to consider PRRT. As you saw, we now have multiple treatment options for our neuroendocrine tumor patients, and more the better, right? We can then not stuck with one or two options. We can really tailor the treatment to individual patients based on what they need. So let's discuss some of the indications why, if a patient comes to my clinic, I recommend PRRT. So the technical answer, the FDA label, is progressive metastatic somatostatin receptor positive neuroendocrine tumors, right? So if you have a neuroendocrine tumor, gastroenteropancreatic neuroendocrine tumor, and you've progressed on somatostatin analog, you can qualify for PRRT. However, in real life, it's not as easy. And as you know, each of our patients are very unique, and you cannot have a cookie cutter templated treatment algorithm. We have to really tailor it to individual patients, and that's where the complexities arises. So some of the straightforward indications when we do recommend PRRT is, one would be a widespread bony metastases. Patients very symptomatic disease, a lot of pain. That would be something that I usually would recommend. It works really well for control of pain and symptom management as well. The other indication would be progressive disease. So patients who've been on somatostatin analogs like sandostatin or lanreotide, and finally the cancer starts growing, especially outside liver. Now, if it's just in the liver growth, we do have other options to consider, like liver-directed therapy, debulking surgeries, ablations, etc. But if the tumor's progressing in multiple areas, multiple sites, especially outside liver, then PRRT is definitely very lucrative option because it is very effective and works well. Now, very recently, Dr. Simran Singh from Canada presented data about NETTER-2. In that study, Lutathera was used upfront as a frontline treatment for more aggressive variety of neuroendocrine tumor. These are grade 2, higher grade 2 with Ki6 of more than 10%, and grade 3 well-differentiated neuroendocrine tumor. So if I am managing an aggressive variety of neuroendocrine tumors which are rapidly growing, or we can even pull the trigger on PRRT as a frontline now based on NETTER-2 study. It was found to be very effective. But typically, for second or third line for patients who are progressing on frontline treatment on somatostatin analogs. This is one of our patients from clinic where, patient had tremendous amount of disease in the bones. You see on the left hand side, the scan showing a lot of black spots. Those are spots which are somatostatin receptor positive tumors. Almost all the bones, especially the vertebrae, are infected with the tumors. And this patient was in significant amount of pain, on dilaudid, and young patient, but affected by this disease. After 4 doses of PRRT, significant reduction in tumor. A lot of these black spots disappeared. But more importantly, this patient came off the narcotics, and was able to go back to work. That's the power of these treatments, and it really impacts the quality of life. And a big believer in using PRRT, especially for this extensive disease, symptomatic disease, bony metastatic disease. Now, the other indication where it's pretty straightforward to use PRRT relatively early in the course would be if we need to shrink the disease. If patient has functional neuroendocrine tumor, that means that tumors are secreting a hormone and giving significant symptoms, be it insulinoma, glucagonoma, carcinoid syndrome, and we want to cytoreduce the disease, we want to shrink it, and patient is not an ideal candidate for surgery, for example, then out of our systemic treatments, out of the medicines, which medicine has a good chance of shrinking the disease? Well, PRRT seems to be among the ones which has a good shot in shrinking the disease. The response rates between 13 to 17%. That means a decent amount of patients will show some degree of shrinkage as compared to everolimus, which is 7% or less, and somatostatin analog, almost nobody or 5% or less will show shrinkage. So out of those drugs, PRRT might be somewhat beneficial in cytoreduction and controlling the functional syndrome, especially if patient is not a candidate for debulking surgeries or liver-directed therapies or other of these surgical interventions. Um, Now, those were some of the straightforward indications. Now, let's discuss a couple of not so straightforward or a gray area where you can or cannot and can have other alternative options as well. So, if you have a patient who is progressing just in the liver, otherwise very stable and no extrahepatic disease or very stable extrahepatic disease, we do have other options that we should be able to consider, that those are liver directed therapies or local regional therapies like bland embolization, Y90, chemoembolization, debulking surgery. In these days you have histotripsy as well for certain tumors of certain size criteria, ablations. So liver directed therapy can be certainly considered, and you don't always have to consider a systemic therapy like PRRT. However, PRRT is very, very effective in liver as well. So it is not a reason not to do PRRT. Again, another reason you need to see a specialist or make sure you get your case reviewed at a multidisciplinary tumor board where all the experts from nuclear medicine who help us make the decision for PRT are there versus interventional radiologists for the local regional therapies and the surgeons, and we can come up with the best plan for the patient. Mesenteric disease, these are the disease in the peritoneal or around your small bowel in the belly. Um, if there is a lot of disease in the mesentery, there is concern for obstruction with PRRT. Although it's a very small concern, and these days we are using prophylactic steroids. So we give a course of steroid for a week during and after PRRT to reduce an inflammation and swelling of the bowels and hopefully preventing the obstruction. But there is a small concern. Moreover, historically we have seen that the disease shrinkage doesn't really happen that much in the mesenteric disease. It works really well in the bone and the lymph node and liver, but the mesenteric disease, at best, we see stabilization. So again, this is one of those disease areas which is tough and challenging to treat, not just for PRRT. Any treatment modality, is not able to really shrink or debulk the disease to that extent. So this is one of those areas where, if there are other options, you can also consider other options. But PRT also is one of the good, effective systemic therapy, but has its limitations. Moving forward, let's discuss some of the other indications where we're not 100% sure about pulling the trigger on PRRT. Poor bone marrow reserve. So if patient has been exposed to a lot of prior treatments, especially with the chemotherapies or extensive use of chemotherapies like CAPE-TEM, one of the side effects, a very effective treatment, the CAPE-TEM, but one of the side effects is long-term issues with bone marrow, and they can have low blood counts or MDS. So if patient has a very borderline low blood counts, low platelets, low white blood cells, I am usually careful with those patients with PRT, because PRT itself can also have effect or detrimental effect on bone marrow in long term. If somebody has a low volume disease, so if you have very limited amount of disease, and those are the patients where I try to use some of the other treatment options before I pull the trigger of PRRT, because again, PRRT is a radioactive drug. It's a radiation based treatment, and there's a lifetime maximum limit. You cannot do PRRT over and over again several times. So I want to save this effective treatment when patient truly has a little bit larger volume of disease. Because if we end up using this effective treatment for a very low volume disease, which could have been treated with other effective treatments, then I've missed out a potential option for the future. So again, discuss with your provider regarding when the best time is, and is the amount of disease justify use of PRT at that point in time. And last but not the least, there are patients who don't have a very avid somatostatin positive lesions on the PET scan. That means the receptor level is not super high. They're not negative either. They're somewhere in the middle, or they're heterogeneous. There are areas which are not lighting up and others are lighting up. Those are challenging cases because those low SSTR expressing lesions might not respond well to the PRRT, while the other lesions which are positive might respond. So you have to really discuss with the patient what are the alternate treatment options are, and before pulling the trigger on PRRT. Okay, so those were some of the gray zone areas, and let's talk some of the indications where you maybe not want to do PRT. And those are pretty straightforward. If you're a pregnant patient, this is a teratogenic drug. Radiation exposure is prohibited during pregnancy. Is not being tested for safety in that area, so that's avoided. That's why you want to get checked for a pregnancy test before, if you're a women in the childbearing age group, before being considered for PRT. If the platelet counts are very low, especially for me, I consider 75,000 or under low, I would be very hesitant to proceed with PRT and look for other alternative options. Um, of course, if there are no receptors, that's the beauty of this theranostics drug. You get to screen your patient. So if the dotatate PETs are negative for somatostatin receptors, the treatment's not going to help, and there is no target. Those locks don't exist for the keys to latch on to them. So that would not be an ideal candidate for PRRT. If the liver functions are not adequate, and there are times where we see this because the tumor has impacted liver so much that a patient has abnormal liver function test, especially if bilirubin is higher than 2 to 3 folds of upper limit of normal, then I'm hesitant in proceeding with PRRT. There is some real world data that heavy liver involvement can be often treated safely, but as long as the liver functions are okay. So that's something to be considered. Kidney functions, again, mild to moderate degree of kidney problems are okay. There is some real world data to suggest if you have renal insufficiency or the GFR up to 40-45 can be considered. You have to be cautious, but anything lower than that is a no go for me, and can certainly cause kidneys to suffer. So severe renal insufficiency would be a contraindication. And of course, performance status. That is a general rule for all the cancer patients for most of the chemo or radiation-based treatments. If patient is very weak and frail and is not in a condition to even get to the clinic, walk to the clinic to get the treatment, that's probably something that the doctor needs to discuss whether they will be able to tolerate the treatment or not. So, in summary, let's finalize some points to ponder. There is some data to suggest that earlier utilization of PRT, that means second line, um, might yield better responses as compared to when used later on third, fourth, fifth line. So there has been a little change in the practice pattern. I think that we've been using PRT more sooner in the course or not, but again, you have to really customize treatment to individual patients and all those factors that I just described before. Long-term side effects with PRRT agent, be it on bone marrow or kidney, uh, fortunately, doesn't seem to be a major concern. We now have long-term follow-up data from NETR1 patients, and the rates of MDS or leukemia is under 2%. So I don't want to trivialize it. It's not 0%, but it's at least about around 2 or under 2%, which is very reassuring. Now, there are a group of patients who have been exposed to a lot of chemotherapy in the past. Now, theoretically, the risk could be as high as 10% with that, but that is yet to be validated in prospective studies and databases. There is a lifetime maximum of radiation exposure limit. So this type of treatment cannot be done indefinitely. There are clinical trials right now which are looking into retreatment with PRRT, newer forms of PRRT like alpha PRRT. So there is certainly some data to suggest that we can re-challenge patients, but again, this cannot be done over and over again several times. So you have to be cautious in picking the right patient at the right time for PRRT and not overuse it when it's not needed as well. With that, I'd like to conclude our brief discussion section on PRRT in nets, when and when not to do it. But again, my final piece of advice, definitely this is general guidance. Please discuss with your oncologist regarding your specific case, because each of our patients are very unique, just like a unique zebra tips. So thank you again, and Ken, for the opportunity to talk, and see you
Yeah.
next time.
Yeah, no, this was great. I really appreciate you doing this again because yeah, this is like a very, very important topic, and I think a lot of people get very overwhelmed by it. I think there's a lot of information. I know that a lot of people say, "Well, this is it. When you take it, that's it. There's no more." So hopefully that cleared a lot of stuff up. And again, who better to talk about this than you?
Thank you, Mike. You're very generous. I really appreciate the opportunity to talk to you. Again, you're a great host, and you bring out fantastic content. So for your viewers, please check out their website. They have some of the best specialists from cardiology, gastroenterology, endocrinology, and of course, some medical oncologists talk about different aspects of nets. So really, it's like an encyclopedia of neuroendocrine cancer in their library. So please check it out. Again, thank you so much, Mike, for having me here. Till we meet again.
Yes, of course, of course. Everybody, thank you so much for joining us. If you have any questions, comments, suggestions, always go to our website, netcancerawareness.org. Of course, the social media is all over the place: Twitter, Instagram, Facebook, at NetCancerAware. Don't forget, our next conference is September 28th, Nashville, Tennessee. It's going to be a great one. And we have another Spanish-speaking live stream. It's going to be really great tonight. Or when you're listening to it, it's probably already out. But July 3rd, 7 p.m. Eastern Standard Time. And yeah, always remember to check us out on the website if you have any questions. And thank you for joining us again on Let's Get Real with NCAN, brought to you by ITM and TerSera.